In AFAB individuals, the hypothalamus and pituitary coordinate with the ovaries to produce a cyclical hormonal rhythm. This rhythm governs ovulation, menstruation, and fertility, and the cycle averages 28 days, but can vary really wildly and be completely normal. Through this axis, GnRH pulses stimulate LH and FSH release from the pituitary, and that directs follicular development, ovulation, as well as corpus luteum function and formation. So, going back to looking at our menstrual cycle, the menstrual cycle begins with pulsatile GnRH from the hypothalamus. That triggers the anterior pituitary to release FSH and LH, and these gonadotropins orchestrate follicular maturation and steroid hormone production. The interplay between estrogen, progesterone, FSH, and LH shapes each phase of the cycle and determines fertility potential for that month. Tying this to the phases of the menstrual cycle is divided into the follicular and luteal phase. This is separated in the middle by ovulation. The follicular phase starts on day one of menses and ends at ovulation. Rising FSH will recruit a cohort of follicles, but usually only one will become dominant. Ovulation divides then the cycle into the luteal phase, during which the corpus luteum, luteal phase, produces progesterone to prepare the endometrium for hopefully the body as implantation. That's like physiologically what the body's waiting for. So early on in the follicular phase, FSH stimulates follicular growth. As the dominant follicle matures, it produces increasing amounts of estrogen, estradiol. Estradiol stimulates endometrial proliferation, growth and development, and it sensitizes the follicle to FSH by upregulating FSH receptors. This increase in estradiol eventually contributes to the LH surge that then triggers ovulation. After ovulation, LH and FSH levels will briefly rise and then fall as the corpus luteum forms. The luteum produces progesterone, which stabilizes our endometrium and prevents additional LH surges. Progesterone is essential for implantation and early pregnancy support. If fertilization does not occur, though, progesterone levels will decline, and that leads to the breakdown of our endometrial lining and the onset of menses. After ovulation, there's two pathways that can occur. If the ovum is not fertilized, progesterone and estradiol fall, and that will destabilize the endometrium, and that will trigger menstruation. If fertilization occurs, the developing placenta begins producing HCG, human chorionic growth or gonadotropin, which maintains the corpus luteum and keeps progesterone levels high. This prevents the shedding of the uterine lining and allows for early pregnancy to progress. Understanding this divergence is essential for interpreting menstrual irregularities and early pregnancy lapse. FSH is released from the anterior pituitary in response to GnRH and is structurally similar to LH, TSH, and HCG by its shared alpha subunit. The unique beta subunit, though, determines its physiologic role. FSH is the primary driver of follicular growth, hence its name, and in AFAB individuals, it's tightly regulated by sex steroids via feedback mechanisms. FSH will promote ovarian follicle development and will stimulate estrogen secretion. It's essential for puberty, sexual maturation, and maintaining regular ovulatory cycles. Without FSH, follicular recruitment and maturation cannot occur, which makes it a central hormone in evaluations of infertility or amenorrhea. FSH secretion is pulsatile and it's regulated by feedback from estrogen and progesterone. As AFAB individuals age, ovarian reserve declines, production decreases, and FSH levels or FSH rises to compensate with that estrogen production decrease. That's why elevated FSH can be a hallmark of menopause. In reproductive age individuals, normal pulsatile fluctuations reflect normal, healthy hypothalamic, pituitary, ovarian, or HPO function. And this is kind of showing those different patterns and pathways. Based off of demographics, we can see different levels. So this gives reference ranges for our FSH. In menstruating adults, levels vary depending on the follicular or mid-cycle or luteal phases. After menopause, FSH will rise significantly due to the loss of ovarian feedback. EMAB individuals also produce FSH, although at lower levels, to support spermatogenesis. And understanding these norms can help determine whether an elevated FSH reflects normal physiology or potentially ovarian failure. There are some conditions or assay application that we can imply here. So a high FSH could indicate menopause, potentially Klinefelters, especially in our AMAB individuals, or early puberty. A low FSH may signal hypothalamic dysfunction, pituitary disease, stress, low body weight, or PCOS. These patterns are really critical in evaluating amenorrhea, infertility, as FSH gives real-time information about ovarian or pituitary function. Now, LH is structurally similar to FSH, TSH, and HCG, sharing the same alpha subunit, but it again has a unique beta subunit. LH plays a defining role in ovulation as the LH surge triggers the rupture of the dominant follicle. LH also supports luteal function by stimulating progesterone production. The LH surge occurs roughly 24 hours before ovulation and is the key hormonal predictor of fertility. After ovulation, LH helps to maintain the corpus luteum, which produces progesterone. Without adequate LH, both ovulation and luteal function become impaired, which can lead to cyclic irregularities or even infertility. It's regulated by estrogen levels, as before ovulation, rising estradiol triggers positive feedback on the pituitary. This leads to the LH surge. After ovulation, high progesterone and estradiol switch the system back to a negative feedback loop that suppresses LH release. LH secretion will remain pulsatile, mirroring GnRH rhythms. With aging, erratic LH surges can contribute to the vasomotor symptoms, such as hot flashes that patients experience, which is not super fun. As I mentioned, LH levels can increase gradually with age, especially after 35, and continue rising into menopause as ovarian feedback diminishes. This pattern helps to distinguish normal perimenopausal transition from premature ovarian insufficiency. It also explains why menopausal symptoms can fluctuate. Hormone levels become irregular before stabilizing at a postmenopausal range. Now, normally LH and FSH exist in about a 1-to-1 ratio. When the FSH LH ratio becomes elevated, especially early in the cycle, it may signal reduced ovarian reserve or impending menopause. A high ratio is more typically associated with PCOS. LH testing is commonly used in infertility evaluations, menopausal assessment, and in determining gonadal failure. High LH levels are usually associated with primary gonadal failure, where the pituitary increases output to compensate for poor ovarian responsiveness. LH also can rise in PCOS, often disproportionately to FSH. Low LH suggests secondary hypogonadism, such as pituitary dysfunction, or may reflect hormone therapy like estrogen or testosterone supplementation, suppressing pituitary output. And this is kind of showing those levels, those rises. All right, when we come back, we will talk about estrogen.